is more than usual. So that can be an issue again. Flap dehiscence, I'm sure so many of the implantologists must have joined and tuned here with me today. Everyone must have at least gone through one or two cases where they must have got any flap dehiscence. Sensory disturbances, that is related to any injury to the sensory nerve. The late complications can occur like perforation to the mucoperiosteum, maxillary sinusitis once we do a sinus grafting procedure, or maybe a lateral window approach. So those things. Mandibular fracture, a rare complication, but I will show you one case related to this. Failed osseointegration, it is also related to periimplantitis and other defects. Bony defects, periapical implant lesions. Carranza has also classified these complications into surgical, biological, technical, mechanical, aesthetic, and phonetic. So surgical, as I said, it can be in the early stage like hematoma, neurosensory disturbances, damage to the adjacent teeth. Biological can consist of inflammation, dehiscence, periimplantitis, bone loss, and implant failures. Technical, like screw loosening, I have also been seen. Implant fractures, a rare occurrence, but I will show you how it can happen. Fracture to restorative materials. Aesthetic, when we want to, especially in the upper anterior aesthetic zone, when we are in a hurry to do the surgeries, so we can have undesired results, and phonetic also includes in that. Hemorrhage, coming to severe bleeding in the postoperative period. So that can be due to the floor of the mouth anatomy, which is so intricate that there is always a vascular channel available in the anterior floor of the mouth. If it is a small type, say around measuring less than 2 millimeters, it's called as peteche. Something bigger is purpura, and bigger than that is ecchymosis. So if you see on the right hand upper photograph, this is what has happened. Severe hematoma has occurred in the anterior floor of the mouth immediately after placement of the implant. The only reason could be possibly because the implant has ruptured or fractured the lingual cortex and hit to one of the communicating arteries in that area. So always in the present dentistry nowadays, there is hardly 2 to 3 cases till date have been reported to have this such hematoma in the floor of the mouth. Always keep a guide, and if possible in the anterior mandible, especially into canine to canine region. Tilt your implant same way like you have a curvature in the bone. This is the anterior part of the mandible which gives a curvature. So always try to keep it perpendicular in the bone so that you have bone either sides. This is chemosis. Whenever you are in my practice, it can happen in 1 in 10 patients. It is common. It is nothing. It is just that sometimes there is a periosteal tear while raising the flap in especially thin biotypes. So the blood can escape into the skin through the mucoperiosteum and give rise to this chemosis. This is one of my patients who had this chemosis on the left lower side cheek, which settled uneventfully with the help of anti-edema measures, what we advised. This is a schematic representation of anterior floor of the mouth, which for the youngsters, those who are watching me, I want to just tell them that there is always anastomotic channels present in the anterior floor of the mouth, divided by mylohyoid muscle in between, and then they ultimately lead to the anterior part of the mandible. So this is the same diagram which I showed that the implant, if you keep it perpendicular in this area, there is always a high chance that you may rupture the facial artery or the lingual or any of the other vessel in this area, which may give rise to hematoma, and it becomes slightly messy and difficult, to unless and until you cauterize it to stop the bleeding. This is a schematic representation of the vascular trauma which can occur. There can be basic bleeding control measures what you start with. It can start with simple pressure to cauterization, and then avoiding and removal of the implants in that area. If you feel that the hematoma is not expanding, it is almost the same size, we can just closely observe, make the patient wait in the operatory for maybe half an hour, check again. If it is fine, it is over. If the expanding hematoma needs really careful observation. If it is expanding, sometimes we might also have to land up into these kind of surgical airways. Otherwise, we might have to ligate it or angiographic embolization. All these things are required. Now, just a word about the various areas where in mandible, starting from the back to front, what are the areas which may lead to bleeding and how do we try to counter it? Starting with the posterior mandible, it is the mylohyoid branch, which can give slight spurt or bleeding in that area. And a slight finger pressure, or you can also hold it with a hemostat, it settles. Coming to the middle mandible, it could be submental. These vessels, they require special ligation, and then only they stop bleeding. In the anterior lingual is the same thing. It is a terminal branch of the submental, which requires compression, vasoconstriction, cauterization, or ligation. So this was all about the hemorrhage part. So I again want to tell that always design your osteotomies, study the anatomy of that area carefully, and then prepare the osteotomy. Neurosensory disturbances, it can be due to poor flap design, especially in the submental area, traumatic flap reflection, accidental intraneural injection, which is transient loss, of course, traction of the mental nerve in the elevated flap, penetration of osteotomy preparation and compression of implant body in the canal. These things are very common in the mandibular body area, especially with the inferior alveolar nerve. The nerve injuries can be intra-alveolar edema or due to the hematomas produced by temporary pressure increase. So in the mandibular canal, it can be direct traumas are most frequent cause of the nerve injuries. It can be due to compression, stretch, overheating, or accidental puncture. For example, if the osteotomy is short, the bone is around D1 type bone, and you are trying to wedge the implant inside, that can give rise to pressure necrosis and prolonged the use of the site can land up into a nerve injury. This is a schematic representation to take care of the mental nerve. The moment it exits out of the mental foramina. Here we have to take the measurements correctly because this loop of the mental nerve, it is always millimeter or two inside. So the nerve is there, especially while tilting your implants, like we do all-on-4 situation. So in those things, we should be careful to take care of the loop. And the downside diagram, you can see, which we have drawn the loop here. So in case this is avoiding me to place an implant in this area, I can also reposition it. That is also one procedure, especially in these kind of mandibles where it is atrophic and due to age-related changes, the mandible has become obtuse and hence the foramen has come right on top. In those scenarios, either we place implants like all-on-4 in the intermental space, or we can as well reposition this mental nerve here. For the youngsters, I mean, you can also use drill stop, those who have just started laying their hands on implantology. So these are also very accurate and they can help avoiding any nerve injuries. The nerve injuries can be further divided into paresthesia, numb feeling, hypoesthesia, hyperesthesia, painful sensation like dysesthesia or anesthesia. So as you all know that if you have anesthesia sort of nerve injury, it is really difficult to come back again, the nerve to come back again, and it requires certain measures to set it right. These are given by Waddington to have these things in your record while you are talking about if you are expecting a nerve injury in the patient, be sure to include a nerve injury as an informed consent. Measure the radiograph with care. Nowadays, we have CVCTs, so you can always simulate the implant or the drill size in that particular area. Consider the bony crestal anatomy and do the correct magnification factor. If the buccal position of the crestal peak of bone influencing the measurement of the available bone, consider the buccolingual position of the nerve canal. The coronal true size tomogram should also be taken as and when required. Always allow 1 to 2 millimeter of safety zone whenever drilling. Take care with counter thinking not to lose support of the crestal cortical bone. This is especially for the immediate implants. Wherever we are planning to extract the tooth and place the implant, try to place as much as wide as implant possible to have better bone to implant contact. Keep the radiograph and the calculation in the patient's chart as powerful evidence for meticulous patient care. In case the implant is too much close, it is always better to remove it as soon as possible. Treatment with corticosteroid, it works wonders. Like I use routinely dexamethasone 4 milligram per ml, either systemic or at the same site. Oral administration can also prevent neuroma formation with the steroids. Coming to the injury to the adjacent tooths, this is also a problem, but used to happen in the pre-CBCT days. But nowadays you have CT, you know exactly what is the dimension, what is the buccolingual width of the bone, and just drive your drill accordingly. Ideally, 1.5 to 2 millimeter of bone should be present between an implant and the adjacent tooth. It is always important to inspection the radiograph with guided pill. Even if you drill 5 mm, it will tell you the exact angulation of the implant or the further guides. To prevent a latent infection with implant, and if you see there is any potential endodontic lesion or a tooth requiring endodontic therapy, it is always imperative, vital to treat that tooth first or before going for an implant. Some cases, the teeth are so much rotated, they require orthodontic correction to allow bone and space for the implant in that particular region. So the injury to the adjacent tooth by malposed implants, you can see these radiographs are so old because I have hardly come across ever this kind of complications after the invent of CBCT scans, and you can use drill guides nowadays. So this is a rare occurrence. Coming to the flap dehiscence and exposure of graft material or barrier membrane, this is, to my knowledge, in my practice, I shouldn't say it's very common that, but it may happen 1 in 10 patients where we do grafting and bone grafting and membrane and other things like GBRs. So contributing factors to dehiscence and exposure of the graft material or barrier membrane include flap tension. If you really suture the flaps tight, continuous mechanical trauma or irritation associated with loosening of cover screw, incorrect incisions, formation of sequestration, and bone debris. This is a very common picture whenever you call the patient after, say, 7 to 10 days when is the revisit to remove the sutures or just for reinspection. So this is wound dehiscence after guided bone regeneration and implant placement using non-resorbable membranes. Now, as we all know, to avoid wound dehiscence, it should be a tension-free closure. Dentures, whenever given, like for a temporary period of time, you should reline with tissue conditioner. Mattress sutures can be helpful with interrupted sutures wherever useful. When a dehiscence is small, see if it is occurring, say, within 24 to 48 hours, I do the same. I immediately resuture the dehiscence. It is always better to do that. Once the diameter of wound increases, say more than 3 centimeters, or the time has elapsed from 2 days to 4 days, it is better to excise or freshen the margins and again resuture. If that is not possible, then let it heal with secondary intention. Ask the patient to do chlorhexidine rinses, and you can load also supplement with systemic antibiotics. So this was regarding the wound dehiscence. Now, the next part, which is a very complicated area, which really needs a lot of skills, and you need to devote time to be good in dealing with the maxillary sinus. As we all know, it is a hollow cavity which is lined by pseudo-stratified columnar respiratory epithelium. It constitutes an important barrier for protection or as a defense for the sinus cavity. So, and even in the present days, may it be indirect sinus lift, or you just bump implant into the sinus.
Patient आ गया ना एक Sorry,
Hello.
sorry. I close it. I put it on.
Okay. So let's talk about the Schneiderian membrane and even if you just with a drill guide, if you are not sure and you don't feel any resistance, you can immediately be into the sinus. So the chances of perforation of sinus is pretty high, say around 10 to 60% of all the surgical procedures we do. So what can be the causes? There can be various anatomical variations such as maxillary sinus septum, the spine or sharp edges which can be present, thick or thin maxillary sinus walls. Angulation between the medial and lateral wall of the maxillary sinus seems to exert especially a large influence on incidence of the membrane perforation. All these things can be picked up in the preoperative phase once you are sure to place an implant or you get a CBCT scan of the sinus in both the oblique as well as the coronal sections, where you get to know about all these anatomic variations. And there are questions about what happens if the sinus gets breached. So according to me, in my experience, if the tears are really small, say around 5 to 6 to 8 mm, you need not do anything about them. They just unfold on itself. If the tears are large, you need ways to get inside the sinus and then place collagen and fibrin adhesive. So make sure that you have a seal in that area. So there are loss of graft material or the implant into the maxillary sinus. This can be due to changes in the intrasinal and nasal pressures, autoimmune reactions of the implant causing peri-implant bone destruction, compromising to osseointegration, resorption process by incorrect distribution of occlusal forces. So like this implant is half out and half in the sinus, this is not going to really work well. So it is better to abort the procedure, remove the implant or do it some other time, or maybe a wider implant, or you can bone graft it and then place it. On the other hand, you have the CT scan, the coronal section of the upper molar area. So if the condition is this, either you abort the procedure or you do a direct sinus and bone grafted, or maybe doing implants at a later stage, or maybe tilt the implants. So in case it happens, you can surgically retrieve, in case your graft material or any implant has gone in the sinus, there are two ways to do it. As we all know, we make a lateral window and then approach through the lateral window, remove the implant, or we can as well do with endoscopically using a 0 degree to 30 degree endoscope through the transnasal route. So prevention can be done for reconstruction can be done with maxilla, which has to be done because what happens, the sinus, you have closed the lateral window, but what about the socket? So otherwise later on, if you just leave it like that, it can communicate. So it requires a tight seal there to avoid any oroentral communication. This is again a very old pictures I could gather from net. The implant installed CT scan, which is displaced. You can see the tooth which is lying horizontal on number 6. Sorry, the implant. So there can be absence or loss of integration, the causes, and loss of stability. The sinus can be, if it is in the sinus, it can be removed in few days. There is, you don't have to really worry about to do it at the same time. You should try doing it. In case it is the patient has spent long time on chair, it is better to defer it for a couple of days and then re-enter while making a lateral window or through endoscopic approach. I would like to share here one of cases which was referred to me by one of my colleagues. So he tried placing immediate implant in upper left side 6 region, upper first molar region. So everything was going fine, but suddenly he encountered while placing a cover screw over the implant that the implant has tipped into the maxillary sinus. Now this patient reported to me, say after 4-5 days. So till the time the whole sinus, he had a oroventral communication because of the wide sinus and the oral cavity communication. And so we had two things to be done for him. First thing, we need to remove the implant. And for that, we did a lateral window here. And then I need to close this communication also, which was really big. So what I thought of taking a buccal pad of fat, which is available in the vicinity, and the fat we tucked inside the lateral window, and then we sutured it somewhere here in the socket. Then socket was again closed with the resorbable membrane. You can see the tissue tag here. Then it was closed with the regular silk or I think nylon sutures. Patient was recalled after 10 days for suture removal. He was completely fine and he recovered uneventfully. There is a small video clip which this is how we do the lateral window with the help of piezo. Sorry for that. And the patient recovered uneventfully, and later on we are still waiting. It's been I think more than 6 months to 8 months. He will be visiting us for further treatment in that area. This is another case which was referred to me by one of my colleagues. In this, what happened? This patient reported after say 3 months for the second stage. So he tried placing a healing screw in that, and the moment he wanted to slightly torque or tighten the healing screw, the implant bumped inside the sinus and traveled slightly anteriorly. In this particular case, I thought of going through the nasal ostium and the lateral nasal wall, which is communicating to the sinus, and it was the best thing to do. We did make a window, the lateral window, which is always required to be done in that area, so that you have a direct approach to if anything goes wrong. And we inserted the endoscope from the lateral nose. Sorry again, and then picked up the implant uneventfully. And this whole procedure took hardly 10 to 15 minutes. Now, just a word about how do you deal with transient chronic maxillary sinusitis either before the treatment or after the treatment. First thing is that you should have a good ENT friend with you who can bail you out of these sinusitis problems because they keep happening. And some people are also allergic. They have allergic sinusitis. So it is better to always have a ENT consultation also regarding these sinus problems. So, but just to name a few decongestant, it can be xylometazoline or application of topical corticosteroid if patient is not diabetic. Perioperative antibiotic prophylaxis like cephedrine can really work wonders for these situations. So here I discuss the another problem, which is malpose in implants. It is what is malpose word means? It is an implant placed in position that is created restorative and biomechanical challenges for the optimal results. So that means you should again always evaluate and see where you are entering, which area, whether what is the bone condition in that area, not just that the implant is stable. I did this osteotomy and anyhow I was able to come out of it. Those type of work doesn't go well in implantology. So like this in the diagram, in implantology, as you all know, that we need to do reverse planning. So we should be sure where we are getting our prosthetic in the end before we do the surgery and place the implants. So always keep that in mind. So these are malposed implants. Precautions, especially in the edentulous aesthetic zone, to rehabilitate using clinical and CT, always rely on CT scans while planning the implants. Use short or tilted implant. In routine, we don't tilt more than 50 degrees. Otherwise, it is difficult for a single tooth to rehabilitate. But yes, whenever we talk about all-on-4 and other tilting implants, we can manage with MUAs and all those things. Avoid anatomical structures at all the time, like mental nerve or maxillary sinus. Coming to the other infrequent complication, but believe me, when I was searching on the net for this thing, I got a lot of articles about mandible fractures. There is a lot of data which has happened while placing implants. So this is one of the cases who reported to us with who was an old patient and he was a diabetic. So one of my colleagues, he wanted to do one nerve lateralization procedure in this posterior mandible and the body of the mandible. And on table, he was not sure whether it is fractured or anything, but it was known that he has breached the lingual cortex in that mandibular body area. The patient went home and came back after 3 days with swelling and moving mandible. The mandible was mobile while opening and closing. So immediately we took a X-ray, and this is the first plate we placed on the body area. It didn't work. This is the second attempt for placing the plate on the upper border. It didn't work at all. So then ultimately we had to take him up for grafting procedure. We convinced him for general anesthesia. And this is the mesh, which is titanium mesh, which was placed down, and then we harvested the chips, cancellous bone, especially from the iliac crest, and then which was stuffed in this scaffold. Also, we suspended, again reinforced the fracture site with the help of this reconstruction plate. This was the OPG of the same patient. After 6 months, you can appreciate the amount of bone which has formed in 6 months. It's been 8 years since I've been following up with this patient, and he's doing perfectly fine. But he's happy with these overdentures we have given him. So it is well known that the central area of the mandible is at the greatest risk for this complication. So reduction and stabilization we all do with whenever you get a fracture. But these type of atrophic mandible where there is reduced blood supply because of the nerve lateralization procedure. So it is really, really a nightmare to treat this kind of fractures in old individuals. Splinting can also be thought of in younger patients with immobilization of fracture. Thin mandibular alveolar crest, which can be, you can think of increasing the width by performing bone grafts. And always, I'll complete by saying that you need tomographic images in all 3 dimensions. The management and precautions, you can use larger diameter implants wherever required, and forces applies to the screw, they get reduced, decrease of preload and increase of thread tightening. One more other complication is implant exposure. So it can happen with any situation. It can be complete exposure of the implant cover screw, removal of the healing cover, flushing the implant. In this situation, we do with chlorhexidine and insertion of permucosal extension. This works wonder. Whenever you have 2-3 collars of the implant visible, you can try this. Oral hygiene with soft toothbrush, chlorhexidine application over the area twice or thrice daily. Other thing is implant fracture, which is actually infrequent complications. We don't see with the newer design, like I've been using this GMI implants for almost 9-10 years now, especially known as Frontier, started adding Avantgarde, which is a other variety. I have never had this complication with these implants. Complication is higher in implant supported fixed partial processes than a complete denture patients. So causes can be defects in the implant design or material and parafunctional habit by the patient. This is again a very old picture, not my case. They have shown that the implant was removed. It was flexured in the maxillary posterior region, and then it was retrieved. This is our patient. I borrowed this case pics from one of my friends. He's a prosthodontist. A non-passive union between the implant and the prosthesis or by mechanical overload. The reason being here is that whenever you call the patient for impressions, they are always hurried to get the final prosthesis the very next day. So exactly that thing must have happened. The operator has not checked the passivity of the impression while like we do a jig trial here, and that was avoided, and hence within 6 months the implant fractured and the prosthesis came out, though the implant is integrated well. So these are difficult cases to treat in case this happens. So never be in a hurry to give the prosthesis. Always see for a passive fit and do a jig trial. So the last part of my presentation comprises of the soft tissue. Tissue is the issue. The soft tissue issues with the infection, starting with peri-implantitis, mucosal abscesses, implant mucositis, hyperplastic mucositis, and fluctuations. As you all know, peri-implantitis is the inflammatory process which affects the tissue around the osseointegrated implant in function, resulting in loss of supporting bone, which is often associated with bleeding, suppuration, increased probing depth, mobility, and radiographic bone loss. So the main differentiating feature of peri-implantitis with peri-implant mucositis or fluctuation is that you will always have substantial bone loss around the implant. The implant can also get shaky in this situation. So peri-implant mucositis was defined as reversible. Yes, this happens in a few of my cases as well, but we take care of it and it settles. So that is peri-implant mucositis, which doesn't have any bone loss in this condition. So the incidence of mucositis is high. It can be 8 to 44, whereas in peri-implantitis, 1 to 19%. So this is with a simple check, a patient will give you history that I get something sticking in my teeth where you have done the implant, and I get some foul smell sometimes. So that can be peri-implant mucositis. You can easily check with a index probe whether how much, if it is more than 3 to 6 centimeter, then it is mucositis. On the other hand, this is the picture of peri-implantitis where you have a crater or a saucer type defect both sides of your implant placement. This is not good for the implant health, but nowadays we do treat these conditions also. What are the risk factor of peri-implantitis? It can be starting from smoking to deep pockets to exposed threads, poor oral hygiene, no plaque control in the particular patient. You can have a saucer-shaped defect, formation of peri-implant pockets, bleeding, suppuration on probing, pain, swelling in the peri-implant tissue, and hyperplasia. So diagnosis can be easily done with clinical indices, peri-implant probing, bleeding on probing, suppuration, mobility, peri-implant radiography, and even microbiological cultures can have been done. The two basic differences between mucositis and implantitis is, apart from these 4 parameters, increased probing depth, bleeding on probing, suppuration, it is basically mobility and radiographic bone loss. So whenever you find mobility and radiographic bone loss both together, then it is unquestionably it is peri-implantitis. These are simple flow charts which tells you that what we have to do in what condition. If the peri-implant pocket depth is less than 3 millimeter, we also usually don't do much than just telling to patient to have oral hygiene instructions and local debridement. If it is more than 3, then there is bleeding on probing and there is visible plaque. So we just clean it and no special therapy has to be done. But if there is any visible plaque and bleeding on probing, then it requires surgical intervention, debridement. And nowadays we do have titanium brushes where we can brush the surface of the implant and then regenerate healing and bone regeneration in that area. If it is severe, say from mild to moderate, then only thing is topical antiseptic treatment, local antibiotic delivery systems, which are same. In moderate cases, we do open debridement. In severe cases, we might as well have to remove the implant and do proper debridement and leave it for GVR for some time and then re-enter. There are other supporting measures like rubber cups, acrylic scalers, which can chip calculus. There can be rinses, which is very important, like chlorhexidine diglycuronate, supplemented by normal chlorhexidine with the water flossers. And this is one very easy to use thing which I prescribe to most of my cases, which comes with chlorhexidine, glucuronate, metronidazole, lignocaine, hydrochloride. And it does have an applicator and it comes in a gel form, and it's a good combination of 2 drugs, and it helps for these situations. Coming to the systemic therapy, we routinely use metronidazole, combining it with amoxicillin CV, 1 gram a day, metronidazole in 3 divided doses of 400 or a single dose of 600. Local application of antibiotic control devices, tetracycline fibers have also been tried. So the surgical thing is when we do the resective surgery, you need abundant saline rinses, flap adaptation, which has to be done again, post-surgical monitoring for several months, plaque control measures to be advised to the patient. Resective surgery, in case is required, we need to do buttonholings in the alveolar margin and do an osteoplasty around the defect to induce fresh bleeding, and then grafting and closing the defect. So coming to the conclusion, dental implant placement is not free of complications. These complications may occur at any stage. Careful analyzing via imaging and surgical techniques and understanding the anatomy, which I want to stress all the time, of surgical area is essential for preventing these complications. The prompt recognition of developing problem and proper management of these things are always required to minimize postoperative outcomes. These are few references which I have gone through, and I feel they are all good to bail you out of these complications. Just maybe 10 minutes more. Am I okay, Dominic?
Yes, absolutely okay. We are on time. Thank you.
Yeah, I'm just, I'll be presenting few cases which we did with GMI implants. And to me, they were not straightforward cases. So just I will share case by case. This is Avantgarde, which is newly launched implant. It's been some time I've started using it. It comes with a mount. This is on the other hand, is the kit, which is a very comprehensive and a small kit. So here is one case, a bit interesting because this gentleman had come to me to refix the bridge. So there was an impacted canine once I took the X-ray, and this guy was aging around 45 years, and since for a long time he was wearing bridge. So what happened in this area, there was the canine was completely bony impacted in the upper left region. And there was a premolar which has gone, which was broken, through which the bridge was suspended with the other teeth. So anyways, I took up the patient. I told him that first you have to get these canine out, only then we can think of some fixed prosthesis we can give you. So since there was a premolar, you can see the remains of the, socket here of the premolar, and this is for the canine in the vertical dimension. I removed both. This was the picture on X-ray on chair of the same patient. This is, I could manage place 2 implants with so deficient bone. This is the bone grafting done. And I had to place the implant slightly palatally because the buccal bone was very weak after removing the canine. This is the on chair picture, and this is exactly after 4 months. You can see how nicely they have integrated, and the bone graft is in situ. And yes, we have rehabilitated this patient, and he's doing fine. This is for the youngsters, those who keep asking me what happens if we bump the implant in the sinus. So see, if it is this much, if just a part of the implant has just gone in the sinus while you were trying to finally torque it, so that is okay. This is 6 months after I did this, and this is the post-operative 6-month picture with GMI Frontier implants. And then we place this healing screws. So it's all fine. Patient has been rehabilitated. This is a pretty old case. So it's okay. But anything beyond this where you want to really go into the sinus, then it is at your own risk. So evaluate that and then go ahead with the sinus. This is again just to show you immediacy done, immediate implants done for GMI using GMI Frontier implants. And I prefer to use the healing screws at the same time in these cases, because why you want the patient to visit you again and again just for placing these screws. Here is a case where we could extract the patient had come for a checkup for a pocket between number 7 and 8 tooth, second molar and the third molar. We extracted both. and same time could place this implant, and it was rock stable after torquing it. This is the Avantgarde which I've used here. Slightly difficult case to manage in these situations because the patients are demanding. This patient was also wearing joint bridge here with these two teeth. It was a failed endodontic treatment. You can make out the amount of cyst which has formed in the palatal area. There was a big breach in the palatal cortex. So I decided to extract and enucleate the cyst there at the first time. And if I could do so, and there is no infection, so I even went ahead and bone grafted it. One thing good about this was that the collarbone was intact, though I didn't try to do immediate implants in that. We waited for 6 months, and after 6 months, I could place these two frontier implants here, and patient is doing fine. We have rehabilitated him. This is yet another case in which the periapical infection was slightly more because it was a failed endodontic treatment in which the upper central incisors, they were not treated well, which had given rise to these, if you can see closely on these CT sections, they had these periapical lesions. So we decided to do everything at once because the patient was demanding. She never wanted to wait that long to bone graft and then re-enter and place implants. So I took a chance. We did the extraction, and that is the day on the surgery and placement of the implants. And this is we sutured with nylon, and this is after 6 months when we are doing the final processes. And this is the same case where this is the actual CT scan in all the dimensions. And this is, if you see closely, there has been these cysts over the top of the apexis. This is how we bone grafted it, left it to heal for 6 months. In between, we gave her temporaries. This is after 6 months. And this is the after 6 months radiograph. You can appreciate the tissue tags in place and healing bone all over. This is the patient with fixed prosthesis. Few cases, they visit us because they are not comfortable sitting on the dental chair for more than, whatever time. They are really reckless and they are old age. They don't want to spend, if you tell them, we want to do your full mouth surgery, upper and lower arches. At the same time, it takes about 2-3 hours. So as well, we do these cases much easily and with all the support in the OT area. And this is, we did a case just last month, and this is how she was rehabilitated with Frontier GMI and Avantgarde implants. This is just after the removal of the temporary, and this is the application of permanent prosthesis. Yet another case in which I tried to just experiment. I mean, I don't say somebody should do it. This is a jaw corrective surgery where I took the mandible back, and then I noticed that she had a broken tooth in the jaw on the right side. Once we did that, then immediately I extracted the tooth, and you can see we inserted one GMI Frontier here. She's doing fine. There was no infection, no anything altogether, no bone loss. Only thing we are waiting for her orthodontist to give me a green signal that the ortho is done, and so we'll rehabilitate her soon. This is our small OT setup in one of the hospitals, and my team, and I want to thank all of them, and very useful tools. This is the WNH physio I use, and the piezotome by Satellite. This is my team. I had a pleasure to, sorry, not my team, my friends and colleagues. I had a chance to visit Barcelona just last year in September with Dr. Amrinder from GMI and his colleagues. And we really had a great time there in Barcelona. I'm looking forward again. To end with, let's come to the do's and don'ts. Whatever I feel like, grade the quality and quantity of bone before jumping to immediate or a delayed type of implants. It is always better to feel what kind of bone structure that area has got, whether it is D1 or it is D4. and so on. Patient physical and psychological makeup. If somebody has got bad habits of too much smoking, and in India we have tobacco chewers. If they cannot stop it, I don't think so they will are going to benefit with this kind of surgical extensions with implants. Plan the processes, then work surgery. So we have to always do a reverse planning. What I do, I have one very good prosthodontist with me in my team. So always show full mouth cases to him, and then we go ahead with the surgery. Prepare the bone to maximize implant length and width. I always feel that the longer and the wider the implant is always better. Use of surgical stents, especially if not in the other areas, I do prefer to use it in full mouth situations and in the upper aesthetic zone. Respect biological aspect of wound healing. Don't be in a hurry. Tell the patient that it's going to take at least a week or 10 days time before you come for resuturing or a suture removal, sorry. So always don't be in a hurry to do that. Avoid premature loading of the implant. I know there are various systems. They claim that you can immediately load and do this thing and other things. But if you are doing a major surgery where you have removing a cyst, placing an implant, and bone grafting in the same time, so it will not be worthwhile to immediately load the implant in those situations. Confirm osseointegration at stage 2. Either use an Ostel, infrared tool to do that, or just by normal torque ratchet to remove it in the reverse direction. That will give you an idea if you just put it on 20 NCM and then try it. Antibiotics as and when required. I don't say that each and every patient requires antibiotics, but whenever you are doing a GBR, wherever you expect any sort of contamination, patient is diabetic, always don't hesitate to advise antibiotics. Lastly, to avoid implants in pregnancy, chronic steroid use, brittle diabetes, radiation, and anybody on anticoagulant therapy. I hope I didn't make all of you or some of you sleep. Thank you so much.
Thank you, Dr. Hines. Believe me, you didn't make us to sleep. It was really interesting. You were just on time, which really appreciated because, you know, when you deal with more than almost 75 or 80 people from all over the world, everyone likes to be on time. So now it's time for your questions. As I've been writing in the chat several times during today, I suggest you to write down your questions in the chat. Please take your time and write down the questions. Our idea is to finish in 15 minutes, so please write those questions. In any case, if we cannot pass all the questions on to Dr. Jain, we would write them and we will send an email to him, and he would directly answer the questions, and we would give you back the answers, okay? But so far, we have a question from Dr. Bikash Das. Dr. Hein, Dr. Das says that I have a patient, serum creatinine level is 1.4, under medication, and who is also diabetic. What precautions do I need to follow before and during osteotomy?
Yeah, that's it. I mean, yeah, it is a good question. Every patient see in our Indian, in India, anybody who's 60 plus, I routinely send them for a CBC and a LFT and KFT just to rule out whether they have got any end stage renal disease or even the CRAT level. 1.4 is not very alarming, but you can always take a urology opinion. And let's talk about diabetes. Anything below 7.8, I take up for surgery. Anything above that, HbA1c, I will not advise to go for any kind of surgery, especially implants.
Okay.
Have I answered it?
Yes, I guess so. I would like to ask if everybody else has a question, has a doubt. Maybe Amrendra.
Yeah, Dr. Jain, I would like to ask a question to you. Like, am I audible to you?
Yeah, please, Dr. Amarinder, go
Yeah.
ahead.
So I would like to say, ask that you are using GMI implants for many years. So can you please guide to our listeners that how GMI implants help you in listing the surgical implications? Like you're dealing with many surgical complications with maybe the patient is coming from outside or whether you require an implant which can hold your trust and bring the best results out of that. So how do you find GMI implants? Because I believe the patient who is using the implants, we will come back even after 20 years. So how do you ensure that GMI implants help you in dealing in such conditions? Because in that condition, they're less poor bone and you would like the results to be 100% sure. So how do you come to conclusion that the GMI is a right choice for dealing with all these surgically and prostatically complicated cases like the
Yes,
designing, the osseointegration? Please, thanks.
so it is a wonderful implant. And last year, I had a chance to visit their facility at Lida, that happens to be in Spain and near Barcelona. And I really, the only reason to visit was just to see, I mean, how carefully they have been designing these implants and what surface coating they are using and where all they are marketing it. So, I mean, I was really their setup and their team of scientists, those who are Dr. Amarinder. So they all answered it that
It seems there is a problem with voice, or it's only my computer.
um,
Yeah, the voice is not clear,
about the
it seems.
designing and other things. And
Yeah,
the other part of the question that is it breaking now or it's clear?
Now it's clear.
yeah, it's clear.
Hello?
Yeah, it's clear now.
Okay, yeah. I mean, the second part is the first GMI implant I did was a full mouth case. And that patient still visits me, not because of anything bad. I mean, for his other family member treatment and other thing. So I'm really happy, ma'am. I think I did that patient in 2016 or maybe 15, and he still visits us with for other granddaughters, this thing, or maybe fillings and other thing. I always ask him everything is fine. So, I mean, I'm pretty sure that it is a good implant with all the components whatsoever. We advise you have got those scan bodies, and like we are into scanning now, and you have MUAs for doing full arch restorations. So it's a complete implant, and the new one which you have just I have gone through is this Avantgarde. I've started using because of the mount comes with it. So it's very easy in the front interior region. We can immediately chair side make the crown, and the patient is also happy for the temporary processes.
Thank you.
No more questions. Either people slept off or maybe they didn't like what I
No,
said.
I mean, people now
Presenting.
people is maybe going for a new implant placement.
Oh, yeah. I also have a case scheduled at after another half an hour.
So, of course, I just wanted to, if everybody has another question, we have still time. I just want to remind you that all of you attendants, that you will receive an email with a link to download the video recorded. So you will be able to see again the presentation, this very, very interesting presentation made by Dr. Jain. And
You can mail me as well directly. That is my mail ID, or you can connect on WhatsApp. So that is my WhatsApp number.
So there is another question from Bilal Hussein. It's as simple as biphosphate complication.
Yeah, biphosphate, if patient, as I told, it is already there, bisphosphonates. So it is avoid implants in pregnancy, steroid, brittle diabetes, radiation, anticoagulant. So that is the same with bisphosphonates also. But only thing you have to see the bone density. Even if the patient, like in irradiation, we talk about any patient who has underwent radiation, it is better to wait for a year before going for implants. Same way for the bisphosphonates in India, I mean, above 60, 70 population, some of them, they receive bisphosphonate. There can be reason for even chemotherapeutic drug, or maybe just for bisphosphonate therapy. It is always to avoid implants in those scenarios.
Okay.
Okay, Dr. Jain, I have one more question.
Yeah.
Like suppose it is widely believed in the dentist circle, like I have meeting many doctors and they're telling that implant is just a titanium and titanium is going to osseointegrate. It's a very common conception, like whether the implant is anyone, that if it's titanium, it will osseointegrate. So I would like to ask a question that is there some grades of titanium which is important, because sometimes when prosthetically wrong, you have to place implant with smaller diameter. Maybe in the posterior region, that time there's chance of fracture. So do you think the implant along with the type of titanium and the other features are also important to prevent from the long-term complications? I mean, in selecting the right type of implant.
Two
What is
things.
your
It has
opinion
to
about
be.
that?
Yeah, that's a good question. I mean, but see, I'm not a prosthetic person, but I do choose my implants well. So anything which is grade 4 and plus is the implant of choice. And another thing is the coatings, what they have to offer. That you can elaborate on. I mean, for GMI, whatever they are selling, I mean, doing it for their implants, it is working fine. And the other thing to see in any kind of implant is that what type of marginal or the crestal bone loss you are getting. So if you are not recurrently getting that crestal bone loss, that means either they are having a polished collar, which is allowing these bacteria to dissipate, not to accumulate in that area, or they are giving a good healing or a seal at the apical end. That is most important in any implant. Rest all are titanium, I agree. But these things, they do matter. It has to be a grade 4 and the type of surface coating, and whether it is a polished surface or it is a normal unpolished surface.
Yes, I totally agree with you, because there are many factors. The titanium, the listeners must and users must understand what's the titanium type and what's the subtype of titanium, and what's the force of the ductility and the malleability and the stiffness, the fracture resistance. All these things has to be consideration in my point. So I believe that not all the implants are equal, and they have to understand the titanium quality. They have to understand the designing. They have to understand the alpha and beta angle. They have to understand the platform switching connections, and all these things comes into picture for long-term survival of the implant.
Yes, yes, true. Everything matters. I have just covered the surgical implications. There is a lot to
Okay.
it.
Yeah. Because it is said that implant patient is married to you, so you have to think before choosing an implant, I believe.
Right. Or you want to keep changing marriages, that's up to you.
Okay,
Any other
thanks.
question, please?
I have another question from Anil Kumar. Patient can leave smoking but want to have implant. Young patient with D4 bone with precautions. What precautions needed?
Young means how young? I mean, if it's, I mean, the patient is adult or he's adolescent, so that way. Anyways, if it is a D4 bone, you have to be really careful while making the drilling. And if the same patient is a smoker also, then it's like you are having two guns pointed at your implant. So it is a weak bone, and then added with the smoking. So definitely he has to stop smoking habit or may reduce it. And the type of implant which you have to choose, it should not be aggressive. It should not be very active implant. And we can do in D4 bone. It's not that it's completely contraindicated.
So patient is 34 years old. 34.
Yeah, 34 is okay. I agree. Even in cases of juvenile periodontitis, you get the same feel and the bone loss, and it can be very soft bone in these regions. You have to underdrill, place a passive implant, not active type, and give it to, don't try to immediate load it. Wait for at least 3 to 6 months Once you are sure about the stability, then go ahead.
I have another question from Alex Lawrence. Hi, Dr. Jain. Good evening. My doctor had a question. After placing the crown in the implant, 2 years follow-up, when he removed the crown, he had got a bad smell from the crown and even from the implant placement area. Placement was good. There is no bone loss. What must be the reason?
Well, there are two reasons to it. Once we put the implant, once the implant is healed, and we take an impression, make an abutment, we mill it, and then final prosthesis, once we put it on the crown, it used to happen with me also. It's nothing unusual. So there could be some nidus. I told you there can be marginal bone loss, maybe a millimeter or two, which is giving the bacteria to come into that area and attracting this foul smell. That is one thing. Number two, when we place the implant, we torque the abutment. Sometimes some people, they put rubber-based material to cover the hole. Some of them, they place a cotton. So for my practice, we use Teflon. Once you use Teflon, I'm sure once you remove the crown, the smell will go. It won't be that bad as it is with the cotton and other materials what you place to close the abutment.
So Alex Lawrence also say that tested with more than 50 patients, all the implant patients have the same reason, he says.
No, is he using Teflon as a cover?
Yeah.
Or he should change the lab, I think, where he's getting the crowns made. There is some space, there is some area which is getting the food lodgement in the crowns.
Okay, I have another, not question, but comment from Rajkumar Bansal, thanking GMI Spain. He's using our implants since many years, and he really appreciates the lectures from Dr. Jain, and he appreciates our team. Thank you very much, Rajkumar. Okay, I don't know if there is other questions. My suggestion, if you have additional questions, please send them to me directly. You have my email address. I was the one sending you all the emails you have received these last days, so you can send them to me, and I will pass them on to Dr. Jain, and I will give you back the answer from him. So
sure.
So
one last question, sir.
Yes.
Like suppose as Dr. Jain told that the patient is 34-year-old and the bone quality is T4. So do you advise to go equicrystal or subcrystal in that type of patients?
Oh, that doesn't matter. A millimeter subcrystal should be okay. It doesn't matter. I think I would go subcrystal. 1 millimeter, not much.
Okay, thanks. That's the better way.
Because there is more chances of bone resorption also.
Okay, so now it's time. Thank you very much, Dr. Jain, for such an excellent presentation, such a clear presentation with very nice clinical cases.
Thank you.
Also for being on time. No, this is very important because we are.
I have that bad habit.
No, because we have many people from many countries, so everyone has their own stuff to do. So it's good to say we will be 1 hour and 15. So we will be 1 hour and 15.
I'm really thankful to all of you, those who have really come forward, those who have watched me about this presentation. And in near future, I'll try to improve or maybe add some new cases. And again, I'll see you sometime. And thank you, GMI, and especially Dominic and Dr. Amarinder for arranging it and allowing me to present it. And thanks again.
Okay, we look forward to meeting you again here in Spain, or maybe in India. Why not? Much better.
I welcome you here anytime.
Okay, so just to finish, thank you to all the attendants. You will receive an email with this presentation recorded. Don't have any doubt in contacting me for any question for Dr. Jain, and everything will be answered. So thank you to all, and see you the next time. Be aware that we will send you new invitations for new webinars very soon. Thank you. Bye-bye. Bye-bye.
Thank you, everyone. I'll take off.
Thank you.